introduce yourself first.
My sincerest apologies. My name is Melissa, and I am a student, and I also work with the advocacy organization Universities Allied for Essential Medicines. For over 10 years, the WHO has been discussing affordable access to medicine and sustainable research and development. Very few results have been achieved. The UN HLP report on access to medicines has been released, recommending once again the negotiation of an R&D convention. How are WHO DG candidates planning on taking the negotiation of this convention forward and other recommendations proposed in the report? Thank you very much.
Thank you. One in the back here.
Thank you. My name is Virginia Murray. I work for Public Health England, but I'm also the Vice Chair of the United Nations International Strategy on Disaster Reduction, Science and Technical Advisory Group. Sorry it's so long. Apologies. That's not the question. You have spoken about the SDGs and mentioned the Climate Change Agreement, but you have not mentioned the other major UN landmark agreement of 2015, the Sendai Framework on Disaster Risk Reduction. How would you use this to advance the health component of disaster risk reduction, knowing that it includes the all hazards approach?
Thank you. There was a question here. Who was it that someone here in the back, the woman in the back, yeah.
Health. The question is, what's your vision for mental health, and specifically, how will you stop the lack of previous attention to mental health damaging health system strengthening and health outcomes in the way it has until now?
Thank you. And one more here in the front. Yeah, you. Yeah. No, in the back, and then we'll come. Okay.
Is that okay?
Yeah.
Sorry. Dr. Joanna Nurse, Head of Health for the Commonwealth. We consist of 52 countries, a third of the world's population, and next year's Commonwealth Health Ministers meeting on the eve of the World Health Assembly is focused on sustainable universal health coverage to contribute to global security. The answers to this will then go forward to the heads of government meeting for the Commonwealth as well in 2018. So my question to you is, how will you convince heads of government to sustainably invest in universal health coverage? And how do we enhance the relevance of health for global security? Thank you.
Thank you. We have 4 questions, and I will pass each one of you the parole, the word, for just 2 minutes. So let me start with Flavia, just next to me.
You would like us to address
anything that you would like to answer in those questions.
All right. So let me start from the last question. I think convincing heads of state of the value of health investment is one of the things that is so important and crucial. As Professor Philip has mentioned, this is a political act. So when you convince heads of state, as I have done in convincing them on the value of investing in women and children, you have to use a range of arguments. You have to use the heart. So you have to appeal to why it is the moral right things to do. You have to use the rights argument, why this is recognized in the legal frameworks, why they have legal obligation to do so. But most importantly, you have to use the economic arguments. What are the returns of the investments that they will put in? And in the case of investing in universal health coverage, I will make the argument not just of how much investing in universal health coverage increases the health of the people, but also how much it increases social cohesion, how much it increases employment, particularly employment for women. We just launched the report that was mentioned, the Commission on Employment for Health, and also how much investing in universal health coverage is something that creates stability, global stability.
Thank you. Thank you.
Okay.
Philippe, one question.
One question about essential medicines. I think that it's terrible to see that less than 1/3 of children with pneumonia in the world don't have access to antibiotics. it is terrible to see that 2/3 of 500,000 people with MDR-TB live in middle-income countries. With it is impossible. It is not affordable for them to buy antibiotics, etc., etc. We have to say that 10 million people wait for treatment for HIV. So we have to work on these essential medicines. 3 things. First, market dynamics. I work on this field for 10 years, more than 10 years. And we, with Unitaid, reduced the prices of antiretroviral for children by 80%, second line antiretroviral by 60%, and malaria, artemisinin against malaria by 60%. Why? Because sustainable and predictable and additional are the three specificities of innovative financing. So it is absolutely clear that we have to take market dynamics for affordability and accessibility. The second thing is to ask industries to continue to produce and distribute old drugs and medicines, very efficient for low and middle income countries. And, to answer your question, we have also the WHO for me has to have a platform, a technical and financial platform with market dynamics, with legal challenges for patents, with incentives like guarantee mechanisms, like technical innovations to allow to develop essential drugs which don't have market prospects. So, and to finish, I think that we have in the room somebody who is very important for us. It is a medicines patent pool. We finance the first patent pool of the humanity in the world. It is a medicines patent pool for HIV. What it is? Today, when a researcher finds a new drugs, a new medicine, it is easy in London, in New York, in Paris, to have at the pharmacy this drug. You have to wait between 15 to 20 years to have the same drug in developing countries. For HIV, thanks to Médecins Sans Frontières, Doctors Without Borders, I founded with the board of Unitaid Medicines Patent Pool. What is it? Mr. Glaxo or Merck or Pfizer or Gilead, you keep your patent. It is your intellectual property. Okay. But allow me to make a license with genericals only for the poorest countries in the world. And we succeeded. And now, after a big fight, we have Merck, Glaxo, Pfizer, and we have the same day, the more recent drugs, the same day for the richest and for the poorest.
Thank you, Philippe. David.
Thanks very much indeed. I was interested that all 4 questions were about areas in which there are clear recommendations relating to what's needed in a particular area, but there are challenges with moving from recommendation to results, whether it's access to medicines, disaster risk reduction, mental health, and global health security. I'd like to just say that in the WHO that I'm hoping to be able to direct, in all these issues, I would like to do the following: to nurture movements among multiple actors that want to make changes in these areas, to build coalitions of leaders who are prepared to come together and make the difference happen, to then demonstrate results that are achieved by these coalitions of leaders, and then to measure benefits and demonstrate their economic impact. in access to medicines. As Philip said, we've got a lot of experience in which we've all been involved to actually get changes in the intellectual property regulations and find ways to get them out. But it's not enough. As this high-level panel that was commissioned by the Secretary-General has shown, there's a lot more to be done. But with a strong movement behind it and bringing different actors together, it can be done and it will be done. When it comes to the disaster risk reduction or hazards as agreed in Sendai, but bringing it into health by bringing together insurance groups, by bringing animal health and human health people together under the One Health movement, and by getting governments to understand the value of prevention. We've been able to shift a bit, but we've got to do much more. With regard to mental health, again, we have to demonstrate the massive economic and social impact that comes from good quality mental health services, particularly for adolescents. And really this is an area, again, where the coalition around movements of people wanting to make a difference and demonstrating results is the only way to do it. And we've got a long way to go, particularly in mental health and emergency settings where the cost of failure to intervene is so huge. And then on the whole issue of global health security, Joanna's point, you know, it is absolutely essential that governments do come together to understand the value of preventing outbreaks from starting through applying the international health regulations, using the new joint evaluation protocols that have been developed in order that we can catch outbreaks in the earliest stages of flaming. And that's where actually heads of government are really interested. And we saw after Ebola that this was an area where the heads are ready to actually say to their ministers, come on, where are our defences against outbreaks? And that's what I'll work on. Thank you.
Sonia.
So on the access to medicines question, which from our colleague on the other side, you referred to the recent Access to Medicine report and you outlined what WHO needs to do. I think we need to be reminded that the recommendations of the Access to Medicine report speak to different constituencies and different organizations and audiences. For instance, there are specific asks of the UN system. The UN system has been asked to convene a special General Assembly session on the subject, and they've asked that an independent task force on innovation be created and that an independent review mechanism be established. There are asks of member states stipulating that member states should fully take advantage of the flexibilities under the TRIPS agreement in relation to the Doha Declaration on Public Health. And it's been recommended that member states should strengthen their patent offices and that wherever they commit public funding to R&D, that they should insist that the benefits accrue equitably to populations, and member states have been requested to insist that information on clinical trials which have been discontinued prior to time should be made publicly available. Then there are asks of the private sector in a number of different areas, and then there are asks of the World Health Organization. The price surveillance mechanism is one specific ask, and the R&D convention, which you referred to, is one. So let's look at things in perspective. And I think with reference to that, there are processes at the UN and in the World Health Assembly. There are intergovernmental bodies, and there are processes which will now take these recommendations forward. And depending on what transpires there, the way forward will be charted out. I don't think that a Director General can take a universal, I beg your pardon, a unilateral decision on how to move forward with these recommendations. But thank you for highlighting this important point. If I may quickly touch upon the...
Let's come back, add it to the next one when we come around with the next round of questions, if you would. Miklos?
Thank you. You know, there was a temptation to talk about how did we break down the pharma prices in dialogue with industry and made pharmaceuticals accessible during the deepest times of economic crisis, world economic crisis and European austerity, or a temptation to talk about the perception of the size of the disease of the Ebola victims, or the close to 1 million suicide, or the 25 million schizophrenic people globally. But I think I should jump on the Commonwealth question. And that is because somehow the health security issue touched the political decision makers. It is on the headlines, and I do not want to gamble on the fear or the fear from political communication. But that made them perceive that there is an area that should be understood more, and they started to understand that a one-day rundown caused by a pandemic outbreak can only be measured by the cost of rundown caused by a terrorist act or by one day of war. So my understanding would be listen. My message would be listen. There is a risk, and there will be a recurrent risk if you don't do something. And you know, all this could be prevented on a consistent presence, building community care, primary care, bringing up human resources for that, if need be, temporarily, the global mobilization of resources, teaching, sharing experiences, and culturally tailoring the interventions. So I think I would jump on that opportunity, and because the rest will come out of it. Thank you very much.
Thank you. So our 4 questioners, have you had the questions answered to your satisfaction? Okay, then we'll move on to the cyberspace, because we have 600 people listening in and sending in tweets. And so, Suri, over to you, to cyberspace.
Excuse me. So we've spent a fair amount of time earlier this afternoon speaking about specific health issues in WHO as an institution, but we all know that health is political, and sometimes those politics are fierce. So what I would like to do is ask the candidates to address one of the most difficult political issues, which is North-South dynamics, North-South tensions that WHO has to address. We may no longer live in a North-South world, but the politics do certainly align that way, and that is reflected in a number of questions that we've received over Twitter. So what I would like each candidate to respond to, and we can start, let's say, from the middle of the table, from David, and go down this way, and then around, is the overall question, as Director General, how would you navigate these difficult North-South issues? And I'm about to give you 3 examples, and you can respond to one of the 3 concrete examples I'll give you, but the real question is, how do you navigate those North-South politics, keeping in mind that the majority of the world's population is, of course, in the South, in low and middle-income countries, and the majority of the money going into WHO's budget, we spent a lot of time talking about that budget, that is coming from the North, from a handful of countries. So here are the 3 questions we got. One is regarding brain drain. Brain drain threatens access to healthcare, and how would you address this, and healthcare workforce planning and distribution? The concern, of course, being that many health workers are being actively recruited from low and middle income countries to work in high income countries where there are also shortages. The second question has to do with perceptions around the international health regulations and health security more broadly, that the health security agenda is only advanced when wealthier countries are put at risk. And that there's a double standard in terms of enforcement of IHR, where there's been a lot of attention, for example, on low and middle income countries increasing their capacities, but not much attention being put on the issue of trade and travel restrictions and how to make sure that countries are protected from undue trade and travel restrictions that might be put in place when they're hit with an outbreak. And then the third is the issue around, again, the high-level panel on access to medicines. And I know a number of you have answered the question on a somewhat technical level, how you would address access to medicines challenges, but I would like to make it, again, very explicitly political. The high-level panel report was issued in September. We know that it has been strongly critiqued by the US government, for example. That's not a secret, that's public information, by certain companies in the pharmaceutical industry. Other northern governments have expressed concern. It's actually not being included on the executive board agenda because there was a disagreement as to whether the EB should debate it. And in fact, it will first be discussed at the WTO TRIPS Council at the intergovernmental level. So these are all, I think, great examples of the difficulty and the persistence of North-South issues. Again, starting with David coming this way around the table, 90 seconds. I'll start my timer. To make sure we get enough questions in. Okay. I'll start waving my hands once we hit 90 seconds. Thank you.
Well, thank you very much indeed. These are not issues restricted to the health sector. Actually, if you look at multilateral governance more generally, there are continued anxieties on agriculture and food, on telecommunications, of course health, and a lot of so many other areas about the extent to which the interests of poorer countries and their people are properly taken into account in the multilateral system. And so I'd just like to say straight away that I think that WHO, as other multilateral organizations, has to have the interests of poorer people, most vulnerable people, poor nations, fragile nations, right at the center of all its work. That is an absolute requirement of being Director General, that you are fundamentally focused on those people who are most in need. At the same time, you have to reflect that you're working within a member state-controlled organization in which there will be continuous negotiations between the representatives of countries, as Saweri just said, about how tricky issues like access to medicines are going to be handled. So my quick summary to answer your basic statement, how will you handle these tensions? One, with a moral position and an ethical position that reflects the absolute importance of equity everywhere, leaving no one behind, equal value for life. Number two, a recognition that within the WHO you operate within a member state environment. Number three, using all the techniques we have, particularly the technical evidence-based techniques that we are as a standard-setting organization, to stimulate a fair and equitable answer to all these questions.
Okay, thank you. 1 minute 49. Thanks.
Was that a song title?
Yes.
I don't think that the framing of North-South tension is the right framing.
No.
I think that the situations that you're referring to, for me, fall into three categories. The first category is a situation when a misunderstanding arises. And I think that the global health security agenda is not a Trojan horse phenomena. It is about ensuring operational readiness in outbreaks and emergencies. It is about protecting the world from the threat of an outbreak, because we know that if there is an outbreak in today's interconnected world, a Spanish flu-like outbreak, more than 50 to 80 million people can die. So I think that this is a question of a misunderstanding, and the strategy there is better communication and trust building by a leader who inspires trust. The second situation arises when one member state has a particular interest and the whole house is held hostage because of that particular interest. And there are many situations, and I needn't cite any examples. And I think the approach to that is tracked to diplomacy by the Director General. The third situation where a tension arises, and it needn't be North-South, is where there are polarizing agendas on the table. And there's a long laundry list of polarizing agendas when we have seen the House hung on for weeks and months and years on end, and a decision just cannot be arrived at, and the agendas just stay there on the table. And I think that that is a situation when the Director General can break an impasse by exercising leadership skills. So that is how I see it.
Thank you. Dr. Soska.
Thank you for the question. And again, thinking through that it is people or doctors or nurses who administer medicines to people, and it is people, trained people who implement international health regulations or stick to it and carry out surveillance. I jump on the brain drain phenomenon. Now, Hungary, as I said, is a donor country. By 2010, 20% of the active Hungarian medical population worked abroad, mainly in the EU. This means in cases that at the Karolinska, out of the 35 pathologists working at Karolinska, 18 were Hungarians. They had their ward meetings in Hungarian. And while at the average age of the employed pathologist in Hungary is 62 years. The response to that was that we made a twinning arrangement in Karolinska, and we put an ethical basis in it that those who are in this twinning and exchange and rotation agreement, those cannot be employed by other Swedish hospitals, and they do it, and they really stick to this, and we can keep them. They receive higher income in the six-month rounds that they carry out in Karolinska, and then they return. They do research programs. The diagnostics times in Karolinska fall down to weeks instead of months. months. So it was a sustainable twinning arrangements. They go abroad for a second and they come back with their higher income and they stay, and there is collaboration built on. This can be done in a south-north, north-south setting, and there can be a global mobilization for that. This is just an example.
Thank you. Let me build on this last comment, because I also find this framing north-south probably not helping us to advance. So if we look at the phenomenon of brain drain, in a globalized world, what we see is actually movement, you just indicated, movement of people, movement of women, for example, that are either moved because of environmental challenges, because of climate change, because of seeking economic opportunities, because they are refugees. And they, in that movement, they actually find opportunities to work, to be what we call provider of care. So we are beginning to define this concept of the global care chain, where this movement, particularly of women, can actually be a positive for the countries where they arrived, and also can be positive for the country where they left, because they can have remittances that come back and that increase the economy of the countries. So in addressing the challenges that you said, I think we need to find ways of reducing the polarization of the debate, number one. Number two, we also need to listen very carefully to what are the positions that the different stakeholders are expressing. Number three, we have to have respect for the cultural values that different parts of the society and different parts of the world are coming for and are presenting to. Because if we make this contract starker, we cannot find the pathway for moving forward. And the organization is a multilateral organization that has to find that navigable path where everybody can agree. Thank you.
I am going to be very concrete about a question on international health security. The WHO is in charge of that, because we have one tool. All the countries are interdependent. So the tool is the international health regulations. Do we want to implement these international health regulations or not? If we want to do that, we have first to implement an operational center directly linked with regional directors and after to country offices. And second, we have to go into each country and to implement a monitoring, and particularly on the borders. Second, we have to implement laboratories for diagnosis and point of care. Third, we have to strengthen the primary healthcare system, because if you come back to Ebola crisis, why Liberia, why Guinea, and why Sierra Leone? Because you don't have any primary healthcare systems. And four, we have to report cases to WHO or in Europe to early warning response system. So, and after that, you have to evaluate. Because when we ask authorities, do we do the international health regulation, everybody say yes. But you have a gap, it's not true. So we have to evaluate, virtually or really, but we have to evaluate.
Thank you.
Thank you all very much for your questions. I'd like to come over to this side now, and we'll take 4 more questions. You can go in the back.
Wonderful.
Yeah. And then
Thank you. Yeah, okay, thanks. I'm Bev Stringer. I work with Médecins Sans Frontières. And I have a question specific for Flavia, if it's okay to ask just one. And it's linked to your health human rights argument. So I'd like to know how you see WHO's role in improving affordability for vaccines, especially for children who are left out of financing mechanisms such as Gavi. And then I've got a question for the whole panel, and I'd like to know, as a doctor, can you tell us the defining moment that has propelled you to want to run one of the most influential health institutions on the planet?
thank you. Just in front to the, yeah.
Thank you very much. Regina Keith, University of Westminster. I have obviously a number of questions. I was there, one question on the global public good and governance. I was in WHO at the Assembly, and so this whole idea of whether you're going to do governance or not really shouldn't even be a question, because the whole Assembly voted that WHO should lead on governance. And I haven't really heard, I've heard a convener, David, you said, Mara, you said about convening. That really wasn't what the members asked for. They want WHO to lead on governance, so I really would love an answer. I was also disappointed on the UHC answer. A lot of you talked very blandly about UHC, and I didn't hear anything about affordability. Sierra Leone, 36 years worth of working, people didn't have access to healthcare because it was too expensive. There's no free at the point of access. We need to have guidance from WHO. What's going to happen on that question, around that, on your answers for that? And finally, on human resources for health, as a nurse midwife, I'm wonderful, happy that you all talked about it. 2006, you asked governments to put $10 per person per year. WHO still has 97% doctors, 1% of nurses, actually she's gone now, so there's less than that in nurses. Health planners, nutritionists. So I really would like some real meat to some of these questions. You've talked a lot about words and acronyms. Please, some technical answers that is going to move things forward so that our children won't have to deal with some of these infectious disease concerns and other problems of public health that we've done for 36 years.
Thank you. Let me move to the front here in the beige. Yeah, stand up. So.
Hi, Giusy Ortu from Malaria Consortium. Neglected tropical diseases are mentioned in the SDG, specifically 3 and 3.8, and they have been in the international public agenda in the last decade as the most important group of diseases that are impacting the poorest population in the world. My question would be what is the position of the future director in regard to NTDs, and how he or she would move forward this agenda that has been mainly pushed forward in the last few years? And if I can ask as well, what would be the next step, most important step in pushing the agenda for NTD surveillance in low and middle-income countries? Thank you.
Thank you. And then the last question from our journalists over here. Do any of you have any questions or comments? This is an open meeting. If not, then one more. Yeah, go ahead. Microphone.
George Zbampat, I'm an economist in London. I would like to ask the panel how they will deal with the issue of religious belief in the implementation of health policies in different areas.
Thank you. 4 good questions, more than 4. Let me start on the other end with Miklos. Answer just one of the questions if you can. Answer it well. And then at the end, we'll have a time when you can come back.
I was still thinking. Let me answer the lead on governance. I think it is, if you think about the pandemic outbreak, that this normative organization took most of the blame. WHO won't be able to avoid taking the blame if the same thing happens. So we have to move forward being more operational, and there has to be a more proactive health governance. This is interconnected by travel, marketing, all the stuff. So WHO should move forward a more proactive health governance. Just like the EU should have moved for a more unified governance, and we were arguing for it during our presidency. So I agree with you totally.
Thank you. David.
Respecting the autonomy and independence of member states, I know.
Yeah. David.
Thanks very much. It's interesting, Miklos's answer provides a taking off point for me, because if you are trying to do global governance on challenging issues, whether they're to do with individual health or societal health, whilst at the same time you have to respect the autonomy of national governments, even sometimes sovereignty of national governments, there are some quite interesting challenges in that. When we're dealing with issues that cross borders, it is really necessary, therefore, to get collective action by governments in responding to those issues. And so to Regina Keith's question, actually dealing with the challenge of global health governance is just not straightforward. And let's just accept that as a starting point. We depend inside organisations like WHO on the capacity of the governments concerned to reach agreement on how they're going to deal with transnational issues as well as inside their country issues. I'd just like to pick up 3 things that I think matter. Number 1, the standard setting is vital. Without standards against which you can assess what's happening, you cannot reach any judgments. Number 2, measurement is vital, and that's where I think the WHO role in providing the base for collective measurements around these issues is so important. Number 3 is having the capacity to identify situations where standards are not being properly realised, even sometimes taking on countries that are quite wealthy that have still got that variation. We have seen this happening in different parts of the UN system. They're not easy things to do. Human Development Index is an example. But I think the SDGs and the fact that we've got some good health targets in the SDGs provide us a new starting off point on getting governance. Number 2, human resources. Let's just recognise the majority of care provision and production of health is done in the household or in the community, usually by people who are not called medical doctors or clinicians. And I do agree that we do need to look at the extent to which the World Health Organization is able to recognise that and to help encourage those who actually produce health to be treated with greater respect in society. There are hundreds of millions of them, and they're usually women. Thank you.
Thank you, David. Sanya?
I'll take the neglected tropical disease question because I'm the only one from the developing world on this panel, and I have seen the ravages caused by neglected tropical diseases, unnecessarily diseases that are totally preventable, and the value of eradicating them in very poor settings. I've seen how disfiguring leishmania can be for young women and how socially excluded it makes them. So let me answer that question. In terms of my commitment to address these, there are several prongs of what I offer in my vision document. Number 1, strong health systems. When health systems are strong, when information systems are in place, when primary care physicians are trained to pick up the problems, when you have functioning health facilities in the most remotest parts of deserts and plateaus and mountains, you pick up these problems and you report them back. Number 1. Number 2, I have expressed a commitment to provide countries relevant support everywhere. And this refers both to the developed and the developing countries, because I think that there is a lot of wealth within WHO's toolbox, and there are amazing people within the organization who sit on a lot of untapped wealth. And the change of culture, the institutionalization of the Director General's virtual roundtables, the real-time connection with the field teams, the country offices, and the ministries of health that I have committed to emanate from an understanding that I have from visiting every region and meeting every member state delegation, except for 2 or 3, over the last, because they were not attending those meetings, over the last 3 months. And I think that it is absolutely imperative that WHO transforms its ability to be able to reach out to people real time in this day and age. And I also want to recognize Sir Eldred Perry in this audience and his transformational work in the area of neglected tropical diseases. The other thing I have committed to is the access to medicine part, because I have said that whenever there's an opportunity for partners to put up a fund together for catalyzing R&D for neglected tropical diseases, or for that matter, new antibiotics to overcome the AMR issue, I, as the Director General, am not going to get competitive and go to DFID asking for more money. I am going to play my role where I have a comparative advantage by quickly putting in policies and standards in place to ensure that that threat is combated. And finally, I have a deep commitment to the poor. I have demonstrated it in my country. I was the first properly trained woman cardiologist in my country, and people used to joke with my husband and say, well, you'll never have to work again, but sadly, he's still working as a banker. Because I ventured to address exactly these kind of issues.
Thank you. Philippe?
No, about the governance, I think that we have, so I agree with tropical neglected disease, and about that, half of them are cured by massively prevention, but the other one absolutely not. So it is a it is a shame, in fact. I agree. About the governance, I think that we have to come back to the ship or 7 ships of theory at the beginning. It is a very, very serious issue. We have to work on the GPG between the DG, the Director General, and the regional directors to have one alone strategy for global challenges. It is absolutely impossible to accept that we have to create a new strategy region by region. It's not possible. So we have to do that together with regional directors. It's true. Not the DG alone. It's true. But when it is done, it is done. After that, we have to implement this strategy according to religious issues, to sanitarian issues, to political issues, to social issues. But it is absolutely clear that we have to do that. The second thing is governance needs also more money. It is not possible to continue with the weakness of the budget. So my life was dedicated during the 15 last years to innovative financing. We can, with $1 per plane ticket, $1 per plane ticket, when I had this idea 10 years ago, $1 per plane ticket. It's painless for the state, it's painless for the traveler. But we convinced 12 countries, and we raised more than $2.5 billion. So, and we used this money to reduce the prices of drugs against HIV, AIDS, tuberculosis, and malaria. So it is UNITAID. So what we did, it is a small experience. We can do that with extractive resources, with financial transaction tax. I say that in the city, but you know. And we can do innovative financing, innovative funding, and innovative spending. And with that, the governance is going to be better.
Flavia.
So I will start with a valuable question that was addressed to me from the colleagues from MSF. So how do we improve affordability of vaccine? First, we must work on the transparency of prices for vaccines. And here I have to appreciate the work that MSF particularly have done in aggressively pursuing that. And we need to extend that. It's now available on the website of UNICEF and also of WHO, but this needs to be made much more available so countries know what prices are they paying. 2, I will continue to work and work more aggressively with Gavi to make sure that the prices of vaccine that Gavi affords for countries that are in the low income can be extended when they graduate, because this is the biggest challenge that we're facing. And 3, I will also look at creating regional purchasing pools mechanisms such as we have currently with the Pan-American organization in PAHO. I also want to take one moment to answer the question that you asked about how do we work, how does WHO work with regional, cultural and religious beliefs that are different. I believe it's possible. I have done it. I worked for 3 years in Sudan, and there I worked with the government and the leaders in the country, and particularly the religious leaders, to address an issue that is a scourge for women, that is female genital mutilation. And the way we worked was to create support the national community leaders, the imam that became the champion for changing that traditional belief. I believe it's possible also to spearhead, and we have done it. I have done it. I led a discussion in the World Health Assembly that has created the first ever global strategy and action plan in the issue of violence against women, against children. It's possible. You have to find the listening mode. You have to find the possibility of dialogue that exists. And you have absolutely to rely on the evidence that the organization can provide to say what are the best policies that are possible for you to address. And then that is your country, that's your national capacity and your national law. But here is the evidence for what policy you can choose that will help you to reduce the impact of violence on the health of women, on the health of adolescents, on the health of children.
Thank you very much, Flavia. So we'll turn over to Suri for 10 minutes, and then we'll come to a close.
Thank you. So 2 pieces of feedback from the public. First, candidates are all focusing on the what and not the how. How will you do all of this without more funding? Second, candidates evade various elephants in the room. For example, no candidate has addressed how to ensure research and development for access to medicines. So I want to fill the room with a few more elephants and hope that you will not be able to avoid them. So let's see, 3 questions, and we'll start with Sanya and then again go down the panel. So first, regarding gender equity. Is gender equity in global health leadership an important objective for the WHO Director General? If so, what would you do to promote this? Second, what steps would you take to prevent undue influence on WHO from the private sector? We had many discussions around partnering with multiple stakeholders, including the private sector, but we know that the debates over the framework of engagement with non-state actors extended for a very long time on this particular issue. Third, one candidate, which is Sanya Nishtar, has committed to making her financing public for the campaign. Do the others on the stage, and we can pose this question, of course, also to Dr. Tedros, make similar commitments? Specifically, and more broadly, do you commit to adhere by the code of conduct that WHO has developed for all candidates? So, Sanya, let's start with you, and then we'll go around. And please speak in Twitter-like conciseness with an aim for 60 seconds.
Oh, la, la. Well, on the gender equity piece, there are certain things that are cross-cutting to policies. They form the overarching rubric for your frame of work. The principles of the United Nations are one such overarching pillars. The values enshrined in WHO's constitution is another. Equity is also an important part of the list, and gender equity merits inclusion in that list as well. Now, the how part, which you've pushed us to move towards, I think that we could start with a female director general. We could, of course, start with balanced gender representation in senior appointments and at all levels, and a conscious effort to move in that direction. We could, for instance, help build country capacity to move towards data disaggregation, because many countries have population-based instruments, and a lot of them, they just give you aggregate figures. So data disaggregation by income status, by gender, by a number of different variables. So I think there are a set of measures that you can do to signal the due respect for gender equity. On the private sector question, I think we now need to recognize that the Sustainable Development Agenda has encouraged us to engage with the private sector, and that the World Health Organization member states during the last World Health Assembly have already approved the framework for engagement with non-state actors. The question is, this is a tricky relationship for an organization such as the World Health Organization, which has a norms and standard work as well. So my answer to this is that when it comes to the setting of policy, you make sure that the private sector does not have a seat at the table. But when it comes to implementation, if you're not going to engage the private sector, you are not going to get the job done. And I think what the private sector needs is respect, because we have been treating them like pariahs for a very long time. And when it comes to implementation, that mindset needs to change.
Sorry, is there a Japanese in the room? We have the same experience. We do not have gender in our language. So the most frequent mistake that I commit in speaking in English is mixing up he and she. So our language is very equitable. And you know, this is a very important stuff. That our work picture is one in that sense. And you know, in the room there is one male colleague with me. And 2 female colleagues, maybe. One from my team and one from our embassy. So it is 2 to 1 to women in the room, according in my team. So that's my absolute open attitude to that issue. The campaign costs, definitely. It's easy. It will be easy. We will publish it. Then the conflict of interest in the public and the private sector. You know, there is this very political correct stuff of calling them non-governmental actors. But there is a huge, huge, huge difference between the behavior and the interest of them. You know, it is, in the public health reform, sorry, it's not a Twitter like, but it will come to the point. You know, it is tobacco. In 76 days, we introduced non-smoking regulation in Hungary. 76 days. There were debates around 10 years, 76 days we could do it. Tobacco industry won. We introduced public health product tax, so it is beverage industry, food industry. Then we broke down the prices. The generic pharma prices were decreased by more than 75% in Hungary. The joint national procurement saved 38% for the Hungarian hospitals. So the pharmaceuticals became more accessible during crisis time. So I took up all the industries, but we did it in a sustainable way. We could come to an agreement. There are some that you cannot come to an agreement, but you can do it in dialogue. And you have to act on this sense, and you have to be brave, and you have to take up the challenge with them. Thank you.
Please remind the candidates to be concise so we can squeeze in
Sorry.
one last round. Thank you.
So thank you. Let me start with the last question, Sueri. Code of conduct. First, I really welcome that this election cycle is so much more transparent and open than we ever had before. And one part of transparency and accountability is also the code of conduct. My government and myself, we have pledged that we will adhere to that code of conduct. And also, for the audience to know, as soon as my candidacy was declared, I am on leave of absence from the World Health Organization, and I will maintain that until the cycle of election is completed. That is designed and done on the purpose that I would not be able to use unduly the influence that I have on the organization. So that's how I demonstrated my commitment to follow the code of conduct. I also want to say the transparency and accountability of the processes we're in calls for that transparency and accountability to continue as Director General. And I have been, among the Assistant Director General, the ones that have insisted that our accountability compact is public, as Sania has alluded to in her comment, and I will insist that that accountability compact is included with the relations with the other leadership of the organization, including that the selection for the leadership position of the organization are much more transparent and open, such as this one we are engaged. My experience is such that when you have open processes, transparent processes, you always get the best talents. Now, 2 more seconds on addressing the issue of the framework of engagement with non-state actors. I think the framework is a first step. Is not exhaustive, but it opens the possibility for governments to engage, and the World Health Organization Secretariat, to engage with non-state actors. And the way that I look at moving that forward is beginning to engage the non-state actors that are maybe most acceptable to government. For example, members of parliament that are the ones that are responsible for the budget, in health budget, that are responsible for the health law, engaging with other civil society organizations, for example, moving for the concept that we actually already started this year of citizen hearing, having citizens that talk to the government and the members of the delegation at the World Health Assembly on what are their expectations on health. And then with the private sector, I believe it's possible to work with the private sector in a way that respect and protect their undue influence by creating firewalls. We would not have been able to have the development of the Ebola vaccine in 1 year, from first phase trial to the availability of the vaccine in 1 year, unless we had worked with the private sector companies that already had brought that product at that stage. On the other hand, when we are writing the rules, when we are writing the norms and standards, there has to be a firewall that protects the independence of the organization. Thank you.
Thank you. Philippe?
Yes, about gender equity, I think the next DG has to implement the gender parity. And particularly at the headquarters level. But for the DG, I think that we can alternate a DG woman, a DG man, a DG woman, a DG man. You agree?
No. I'm just noting your logic.
About the non-state actors, I think that we have to divide non-state actors in NGOs, of course, and private sector. About NGOs, we have to work with NGOs now more than before. When we see the Ebola crisis, we see the importance of Médecins Sans Frontières and others. So I am in favor of have structural links with NGOs and communities of patients. When I was chair of UNITAID for 10 years, it was impossible for me to move forward without the civil society. It was impossible. The second thing is about private sector. 2 examples. One, outbreak. During an outbreak, we have the WHO should convene governments, industry, private sector, researchers and donors to accelerate the development of the urgently needed drugs and vaccines. Other example, NCDs, obesity for children. It's a catastrophe today. So when we see that, the norms, the influence of the food proceeding, the food industry has in this field 2 remarks. Absolutely none people in the WHO can have a conflict of interest with the private sector, and particularly with food industry and pharmaceutical industry. And second, we have a dialogue to establish norms, because we have norms for all, except for salt, sugar, and fat in all the countries. So we have to work with private sector, but the WHO has to be the leader and not the food industry.
I want to try to approach some of these questions in a slightly different way, because I can understand the anxiety that WHO perhaps has not invested enough in research and development in certain areas, but at the same time, I'd like to stress that for me, investing in R&D is a means to an end. The end is whether or not there is health equity, there is equivalence of outcomes in different population groups. And so I'd like to stress that I think the role of WHO is often to identify where extra research is needed and to set out blueprints for where that research can take place and to review progress, but very rarely to do the kind of very direct involvement in research, usually only when nobody else does it. So let us keep, I think, recognizing that there are some times when WHO has to actually create an environment within which others do things rather than doing it themselves. I want to try on the issue of gender equity similarly to recast the question. I mean, for me, WHO needs to be able to approach issues of health from a 100% feminist perspective. The whole organization needs to be a feminist organization. And in that regard, I think it is conceivable, though I haven't kind of worked out in my head how you would test it, to say that everyone in the organization should be a feminist, regardless of their sex. So did you actually develop a workforce which is totally feminist, and in the same way, everybody in the organization should respect diversity with regard to disability issues. Everyone in the organization should respect the importance of ethnicity as a defining feature of people's lives. Yes, I believe that there ought to be greater gender equity in the organisation, just as there should be right across the UN. But for me, that's only part of the issue. The issue is whether the organisation views issues of health through the eyes, through the hearts and through the heads that women view them through. And I'd like to see men being encouraged to do that more. Thank you.
Thank you, David. I'm afraid we've run out of time for another round of questions. So please join me in first thanking our candidates.